The one thing I haven't mentioned with kidneys actually is if your kidneys really are impaired, your kidneys produce a hormone called erythropoietin. And erythropoietin helps you produce red cells. Red cells are required to carry hemoglobin and oxygen to provide you with energy. If you're anemic, because you're not producing enough red cells, you can become quite fatigued and tired. And a way of managing that is to just give you a top-up of blood. But if your kidneys aren't working as well and you're not producing this hormone erythropoietin, it may be of benefit to actually have this erythropoietin, which comes in a little injection in the tummy about once a week. And people that have significant kidney problems, all of those people on renal dialysis for their kidneys will be on erythropoietin to help increase their red cell count. So does anybody take that drug? Yes? You take erythropoietin? Yeah. Your kidneys aren't working at all, or? About 30%, yeah. And do you find the erythropoietin helps?
I've just had 4 injections, so I'm not sure, but I think from my last transfusion, I was having transfusions monthly.
Yes.
I think I'm getting a little bit longer
duration,
6 weeks.
yeah.
But yeah, it's early days yet.
Yeah, so this lady is very anemic, maybe for other reasons, but perhaps also because her kidneys aren't working and she's not producing a hormone that helps her produce red cells. And so it can take 4 to 6 weeks. They say give it a good 6 weeks to see any benefit. And so that increased duration between the blood transfusions you require may be a sign that that's starting to kick in. Yeah.
Just a little question.
Yes.
Dialysis.
Yes.
Do many patients really bother with dialysis? Multiple myeloma patients?
Yeah, so the question of renal dialysis, do patients bother with renal dialysis if they've got multiple myeloma? Well, that they certainly do if they require it. We would, if you have poor kidney function, you should be being managed by a kidney specialist, and they will manage you in terms of when you get to a point that you may require dialysis, and that can be different in different people. But certainly if you get to the point that you require dialysis, you are going to be very, very sick if you don't have dialysis. So there would be no reason not to go ahead in a similar way that if you had another reason for your kidney problem to go ahead and have some dialysis, because it will make you feel a lot better. And it would be very, very unsafe not to go ahead and have that dialysis. So we certainly have a proportion of patients that we manage that are on dialysis. It adds another dimension to their needs, their health needs, because if you do need to have dialysis, that's ongoing and you have it regularly. And we need to manage the medications for your myeloma with your kidney function in mind. But it certainly is doable. I've certainly nursed many patients who are on dialysis that we have even taken through a stem cell transplant. It's not a reason not to do it. We just need to be mindful, and we need to moderate doses and timings, etc. So we don't put medications into you and it gets flushed straight off on the machine. So it certainly adds another difficult dimension, but it doesn't necessarily mean that we can't manage your myeloma in a very similar way that we would do otherwise. So I would take the advice of your renal physician. If you require dialysis, then he's not going to offer that lightly. We don't sort of do it in advance. We do it when it is required, and you would feel very, very ill if you didn't have dialysis. Yeah. Any other questions about kidneys before we move on to bones? No? Okay. So myeloma bone disease is probably one of the most common complications associated with myeloma. As I said, the majority of people actually come to a diagnosis because of a bone problem. You'll read anywhere between sort of 80 and 90% of people with myeloma will have a bony component to their disease, but the severity of which people have a bony component is very individual. It used to be in about sort of 15 years ago that we saw a lot of very nasty bone disease, a lot of fractures, people shrinking. Has anybody shrunk? I know the gentleman spoke to me. Yes, lots of people have shrunk. And that's not uncommon, because it's not uncommon as we all age, but in myeloma, the areas of bone commonly affected include the vertebra, and if the vertebra collapse a little bit and shrink down a little bit, you shrink down with it. On average, people tend to lose about 2 inches of height with a diagnosis of myeloma, but I have seen people who have lost up to sort of 8 inches in height, which is significant if they've had a lot of vertebra involved. So the common bones that are affected include the vertebra, as I said, in the spine. The ribs are very common. Has anybody broken a rib? Yep, lots of hands going up. I had a gentleman last week who phoned me and he said, my rib hurts. I had a chest infection. I coughed a lot. I think I've broken one. And indeed he had. The ribs are commonly affected, and they're a tricky bone to intervene with, because you can't sort of, you wouldn't strap a rib, and certainly the ribs in their positioning move with any slight movement, including breathing, and you can't not breathe and not laugh and not talk. So it is a tricky bone to have affected. And other bones include the long bones, particularly sort of the hips and the long top of the femurs can get affected. But any bone can get affected. And how does that look? What is the clinical picture of bone disease? Well, as I said, a general thinning. So a general thinning of bones is called osteopenia, or a more severe thinning can be an osteoporosis. If you have some thinned out areas that are extensive, then that bone can fracture, particularly if it's in an area that comes under a lot of stress. A gentleman over tea was telling me he fractured one of his vertebra moving a pool table, wasn't it? Yeah, gentleman at the back. And I've had patients who fractured a vertebra when they've picked up heavy luggage. So be careful with anything that is weight bearing if you do have areas that are particularly at risk. As I said, it can cause a high calcium in the blood, because if you have bone loss, it can leak calcium into the blood, and so patients can have something called hypercalcemia, usually more common at diagnosis when we haven't really started to manage your disease, but it can cause symptoms of confusion, constipation, thirst, etc. Those are very common symptoms of having a very high calcium, and a simple blood test would identify that very quickly, and the best way to manage that is to give you a dose of a bone strengthener which binds to extra calcium and draws it out, and to flush it out of your system. And most commonly, bony problems can cause significant pain. Who would say they've had significant pain from bone? Yeah, lots of hands going up. It's a very common, unfortunate relationship in myeloma between the bone disease caused by the myeloma cells, and we need to manage that actively. So what is it caused about? I told you briefly about these cells. We have these nice little jellyfish things here. Osteoclasts break down bone, and osteoblasts come in and fill up bone. And this is happening in a constant process and a state of equilibrium. But it is the names of these two cells, osteoblasts and osteoclasts, that you may hear if you start to do some reading around myeloma bone disease. Because particularly some of the newer agents and some of the newer ways of managing myeloma bone disease are actually to act upon these cells. And myeloma osteoblasts that build bone, we want to encourage that, and we want to discourage the activity of these cells that break down bone. And some of the new drugs are beginning to show evidence of actually doing that. And I mentioned before that there is this nasty relationship and vicious cycle that occurs in myeloma with bone, where you have this picture just shows our myeloma cells here and our osteoblasts that build bone and osteoclasts that break down bone. And a vicious cycle of dependency occurs that results in bone being broken down and you getting bone loss. And that happens because a variety of different factors, you can't see here very well, and these chemical messages are sent out by these myeloma cells that stops osteoblasts working and increase the activity of osteoclasts. So you have an imbalance. And just to say thank you, the osteoclasts send a message back to the myeloma cell to say thank you very much for that, let's have more myeloma cells. So managing myeloma bone disease is about trying to block and inhibit this process and readjust the normal balance back to give you strong and healthy bones. How do we manage myeloma bone disease? Well, one of the important things in order to have a good look at your bones is to do some scans or imaging. One of the commonest things we would do is to do what's called a skeletal survey, which is a full set of plain x-rays of the body to see where you may have at-risk lytic lesions or weakened areas. Being able to assess where these weakened areas are helps in those people that have asymptomatic disease to tell us whether we need to treat. but also if you had a particular hotspot or a lytic lesion in an area that's of high activity, such as your hip bone, we may actually then refer you to an orthopedic surgeon and say, look, this person has some wearing and a lytic lesion or a myeloma thinning or deposit in this area, and they're at risk of having a fracture. Could we just jump in early and actually fix this hip, maybe replace it, and prevent you having further problems in that area? Skeletal survey is sort of the gold standard of imaging, but certain times, particularly if you have evidence of myeloma in the vertebra carries the spinal cord. So it's an area that if you do have an active deposit of myeloma or bone disease, can impact on the spinal cord, and therefore we might want to do some more sensitive scanning. We might do an MRI or a CT scan to particularly look at that area. Or myeloma bone disease, if there is a deposit of myeloma cells, and you can actually get a sort of solid deposit of myeloma cells that we might call a plasmacytoma, which a gentleman at the back was telling me he was diagnosed with, and you can actually have this as a single deposit, and we'll call that a solitary plasmacytoma, then they are very, very responsive to radiotherapy. Has anybody had some radiotherapy? Yep, gentleman down the front here. If you do have a few people around, if you do have myeloma cells are very responsive to radiation, and if you have a deposit and we irradiate that area, we will need to do a scan, probably an MRI, to look very carefully at that region so that the radiotherapy technicians can plan very specifically where they're going to target for some radiation. And that can shrink the myeloma deposit down, reduce pain significantly, hopefully, and get rid of the plasmacytoma in that area. So a very useful supportive measure in the management of myeloma bone disease. Some of these other scanning techniques I've included just in case anybody has been exposed to them. We don't standardly do DEXA scanning or this nuclear imaging techniques on people unless there's a particular part of your body that is giving us concern. So I've included them here just in case you have been had one or are told about them in the future. At this stage, we certainly don't do routine scanning of PET scanning, which is a nuclear imaging scan to look at specific areas where there might be active myeloma, because it doesn't yet impact on how we manage your myeloma. And it's an invasive scan and costly, and we only have, for example, in New South Wales, I think 3 PET scanners, so it'd be very difficult to do that for everybody. But there are lots of different imaging techniques that you may hear. Does anybody have any questions about particular scans or?
Yeah, how often should we have a skeletal survey?
How often? That's a very good question. How often should you have a skeletal survey? Certainly at diagnosis, it's part of the diagnostics to determine how much myeloma you have around and where it affects your body. Then after that, it depends on the activity of your disease and whether you're in remission or stability or whether you have symptoms of recurrence of bone disease. We tend to do skeletal surveys when we do a full restaging, and a restaging is the full set of those tests that you had at diagnosis, including a bone marrow biopsy, looking at the myeloma protein, at your other aspects of your general health, and a skeletal survey. And we don't do that routinely, say, every year, but we do it at periods where we are suspicious that things are on the move. Then we will do restaging. A typical time to do restaging is about 6 months after your transplant, because that's a good time just to see and assess how well you have responded to all of that treatment. After that post-transplant period, it's a restaging that is done when there is suspicion that things are moving on. So if your myeloma proteins are starting to rise or you're becoming a little anemic, your specialist may say, let's do some full restaging, and that would include some x-rays. Or if you're aware that bones are at risk and you had a new pain or a new bony issue, you need to flag that up to your doctor, and he may well do a full set of x-rays, or he may just x-ray that area and make sure that there's not something going on there that they need to manage or intervene with. The balance always, isn't it? We don't want to expose you to radiation unnecessarily, but sometimes we need to find out what the problem is. Okay?